Okay, let's unpack this. Welcome to the deep dive.
Glad to be here.
Today we're diving into some really critical source material. It's excerpts from the Central Retinal Artery Occlusion Protocol 2025.
Right, a document that outlines a very urgent, very systematic approach.
Exactly. Our mission here is to break down this protocol for managing central retinal artery occlusion, what many call an eye stroke.
And it really hammers home treating this like a brain stroke.
Yeah.
Speed, structure, multidisciplinary effort.
Absolutely. This deep dive is really for you, focusing on those critical steps, the super time-sensitive decisions needed to, maximize vision recovery and prevent other issues down the line.
What strikes me immediately is how this protocol frames central retinal artery occlusion. It's not just serious, it's a true medical emergency.
Right from the get-go. Action stations the moment a patient presents.
It kicks off with the ophthalmologist's rapid clinical diagnosis, usually, based on that sudden, painless vision loss in one eye and what they see in the fundoscopic assessment.
Looking into the back of the eye, yeah. And that initial diagnosis is the trigger, isn't it?
It is. And straight away, even while prepping for more definitive care, there are these urgent first-line things to try.
It's like ocular massage.
What?
Or using drops. Or maybe oral meds like acetazolamide to get that eye pressure down quickly.
Exactly. But there's another immediate, absolutely critical step for anyone over 50.
Screening for Giant Cell Arteritis, GCA.
Non-negotiable. Because, it's a potential cause that isn't embolic, and crucially, it threatens the other eye.
So the protocol demands an urgent blood draw, ESR and CRP.
Yep, erythrocyte sedimentation rate and C-reactive protein. And here's the really key part. If you strongly suspect GCA clinically,
You don't wait for the lab.
you absolutely don't.
Yeah.
You start high-dose systemic corticosteroids immediately, empirically.
That immediate steroid treatment is vital, protects the vision in the other eye.
Precisely. So speed and clinical judgment drive those first moves. Then we get into the hyperacute reperfusion therapies.
Okay, these are the time-sensitive treatments aimed at restoring blood flow. But they come with risks, right? Needs careful discussion, maybe involving a stroke neurologist.
Definitely. Intravenous thrombolysis using a clot buster like Ultiplase is a major one.
But only for very select patients. Caused by a clot, and within that really narrow window.
Extremely narrow. Less than 4.5 hours from symptom onset. That's tough in practice.
And you need that urgent brain CT first, non-contrav.
Mandatory. Got to rule out any brain bleed or even a simultaneous stroke before giving the drug.
Yeah.
And, of course, exclude anyone with contraindications.
If you go ahead, it's IV Ultiplase, specific dose, mostly infused over an hour.
Correct. And that requires an intensive care unit setting. Constant monitoring, especially blood pressure.
A significant intervention. That time window is a real challenge. Does the protocol mention hyperbaric oxygen therapy?
It does, yeah. That can be considered often for patients presenting a bit later, maybe up to 24 hours out.
Or perhaps as a salvage therapy if other things haven't worked.
Potentially. The protocol outlines sessions breathing 100% oxygen at increased pressure with adjustments based on response.
Now, this is where it gets really interesting for me, that idea of parallel pathways. While you're assessing or even giving these acute therapies.
You simultaneously have to launch an urgent workup to find the underlying cause. You can't wait.
Exactly. Because finding that cause is what guides prevention later on.
Absolutely. So that workup includes neurovascular imaging. Things like a carotid duplex Doppler ultrasound.
Checking for blockages in the neck artery.
Right. And that mandatory non-contrast brain CT done before thrombolysis also plays a role here. And magnetic resonance angiography might be an option too, if CT isn't available, though maybe slower.
And you also need a solid cardiac evaluation, looking for clots coming from the heart.
Yep. If the carotids look clear, the heart's next. The protocol actually prefers a transesophageal echocardiogram. The scope down the throat gives a really clear view.
But a standard transthoracic echo is okay if the T isn't feasible.
It's an acceptable alternative. Plus, you need electrocardiogram monitoring continuous or maybe a Holter monitor for 24 to 48 hours.
Screening for those tricky, irregular heart rhythms like paroxysmal atrial fibrillation.
Exactly, a common source of clots. And then there's the blood work.
Right, a comprehensive panel. Fasting lipids, hemoglobin A1C for diabetes.
And potentially a hypercoagulability screen, especially maybe in younger patients or if the cause just isn't obvious, looking for underlying risk factors.
So once you hopefully find that cause, the focus shifts to secondary prevention and ongoing management.
For sure. If it's confirmed embolic or atherosclerotic, you need aggressive secondary prevention. That means antiplatelet therapy, often following stroke guidelines.
And high-intensity statins like atorvastatin, 80 milligrams, pretty much regardless of baseline cholesterol?
That's the standard now, yes. Plus, optimizing blood pressure, diabetes control, pushing smoking cessation, all the vascular risk factors.
It really underscores that an eye stroke can be a serious warning sign for systemic vascular disease.
Definitely. And none of this happens in a vacuum. The protocol heavily stresses that seamless, multidisciplinary team approach.
Coordination is everything. Getting those investigations done fast, consulting neurology, cardiology, internal medicine.
And ensuring prompt communication back to the primary ophthalmologist and arranging their follow-up post-discharge. It needs to be a connected effort,
The protocol also mentions logistical things, like referring for immediate admission to specific hospitals and collecting data.
which points towards standardizing care and continuously learning, improving how these emergencies are handled system-wide.
So let's pull this together. What does it all mean? This protocol really frames central retinal artery occlusion as a true emergency. It demands the kind of speed and structure we associate with brain stroke care.
From the instant diagnosis and initial measures through considering time-critical reperfusion therapies and that simultaneous urgent investigation for the cause, it's all about being swift and thorough.
What I find compelling is how the protocol balances those two urgent tracks, initiating potentially risky, sight-saving treatments.
While at the same time, urgently digging for the systemic cause to prevent something worse happening later. It's a parallel process.
Which brings us to a final thought, something for you to consider in your own setting. How do we best integrate these parallel urgent pathways in practice?
How do we make sure they run smoothly, efficiently, ensuring no critical time is lost on either front, saving the eye and investigating the systemic risk? That's the ongoing challenge.